Good afternoon. Welcome to you all for the post-lunch session again. Anyway, we are having, of course, very much we are focused on diabetology and lifestyle diseases. Now we are back to our old traditional respiratory system to give a talk on precision medicine in bronchial asthma. We have none other than Dr. P.A. Mahesh, who is Professor of Pulmonary Medicine, JSS Medical College. I have heard a couple of his lectures earlier also. Over to Dr. Mahesh, sir.
Yeah, thank you. Thank you, Chairperson. So at the outset, I'd like to thank the organizing committee for having given me a chance here, and Dr. Murali Mohan for having me here. So this is a novel topic, I think, and there is still a long way to go. So I will try to cover this in these sections. First, we will see what is precision medicine and how it has evolved over time, and most importantly, I think for clinicians, how do we use it in our clinical practice at present? What is the current global standards? We mainly look at treatable traits. GINA guidelines is just a very basic people to get an idea, but that's just the beginning. But you want to give more advance, then you start talking and looking for treatable traits. Some studies in Mysore to add to that, and what we can expect in the future. The future is all about molecular biology, and we'll go quickly into that depending on the time. When the chairperson will ask me to stop, I'll stop, and then a quick conclusion. So what is this precision medicine that is now, I think almost all subjects people talk of this topic, not only in asthma. Now this can be defined as an approach to treat and prevent disease by taking into consideration the individual variability in genes, epigenetics, other omics, which includes proteomics, metabolomics, transcriptomics, metagenetics, environment, and lifestyle for each subject. You don't know how difficult that is. And by taking this approach, we are having a good likelihood of the right patient, the right drug at the right time, for not only for treatment, but also for prevention. So this is the concept of the P4 medicine: predictive, preventive, personalized, and participatory. Now, when we talk of this phenotyping, what is this phenotyping? It is an observable characteristic of an organism. This is an interaction of a genotype with the environment. This is what determines the phenotype. Now, the earliest phenotyping we know, I'm sure we all read as MBBS students, the old us. We looked at intrinsic and extrinsic asthma, first formulated in 1940. Now we have other clinical phenotyping, looks at the GINA grading of severity, GINA grading of asthma control. We also have subgroups: early childhood, late childhood, adult onset, geriatric asthma, menstruation-induced asthma, pregnancy-induced asthma, obese asthma, aspirin-induced asthma. All these, you can say, are all different phenotypes. But in 1990s, people started realizing that yes, steroids work, bronchodilators work, but not all patients respond to the same degree, and there's a huge variability in the response, which means then they started recognizing that asthma is a very heterogeneous disease. And very early, what happened was they were all hypothesis driven, and most of the studies then identified, most of it happened in UK, and most of the studies identified single pathways. They found out an eophonic dominant asthma, they found out a fungal sensitive asthma, IL-5, IL-6, IL-4, 13, IL-17. So a lot of these studies, early studies, looked at particular pathways. But then they realized, and we have done a lot of these studies and realized, looking at single, isolated, really doesn't add much. But asthma is much more complicated than a single pathway disease. Now later studies started taking less biased approach. The classical one is the Severe Asthma Research Program, called the SARP, and they got about 4 clusters in that. Then so many other studies followed, which had about 4 to 10 different clusters. These were all the different variables that were used to cluster the patients. And then you have this UBioPred training cohort, again in severe asthma, had 4 typical groups, and these were all severe asthmatics, but some were steroid dependent, some were well controlled, Some did not have much of obstruction, though they had severe asthma. Some had severe obstruction, some had severe exacerbation, gender differences. So, a lot of differences people started observing and were quite confused as how to practice this in routine clinical medicine, how do we place this. And this is again just to look at an eosinophilic inflammation and symptoms. Now, patient here has low inflammation, has low symptoms. Patient here has high symptoms, but low eosinophilic inflammation because they have other inflammation such as a neutrophilic inflammation. Here we have so-called poor perceivers. You have a lot of eosinophilic inflammation, but corresponding to that, patient says lung function is 20, and then he says he is quite fine. So they were quite discordant, either in their symptoms or their inflammation. Now in this, what do we do now? How do we actually bring it into clinical practice? I think this is where the concept of treatable traits is important. I call it clinical precision medicine. It was first formulated by Alvar Agusti in 2016. And what they do here, they don't classify like asthma, COPD or ACO. All these are removed. You just look at a particular trait, and this is based on the genetic and phenotypic and psychosocial characteristics. And a combination, of course, these are all based on the endotypes. So we have, they don't label it as I said, and these are classified as pulmonary, extrapulmonary and behavioral. I'm sure you know more of it than I do. And these are the main treatable traits that look at it. Now the usual care, the treatment is not appropriately individualized. But when we talk of a treatable trait, now you see, we see this group of patients, say 100 asthmatics. We try to classify them as phenotypes, obese, aspirin-induced, eosinophilic, we try to classify, but then people realized they are not very clear cut. And finally, if you really go into the depth of it, what you see is every single patient has a combination of several of these characteristics, and that is why treatable traits are important. So how common are these treatable traits? This is a large study called the novelty study, more than 11,000 subjects in 19 countries. This is a whole list of them. We will go through them in the next slides. But what were the most common? Non-reversible airflow obstruction. Patient comes to you with asthma, lung function is 60, whatever you do, lung function remains 65. It is a fixed airway obstruction. People used indoor use of biomass or coal, and these are not only common in India and Africa, they are also common in Western countries. And 30 to 40% of them have a frequent productive cough, rhinosinusitis, so-called T2 high asthma, occupational exposures, frequent reliever use. Now, if you take a patient with asthma, on an average they have 4.6 treatable traits, COPD has 5.4. When you have an asthma COPD overlap, you have something like 6.4. Why are they important? As the number of treatable traits increases, the patient's quality of life starts becoming poor. It's a very, very strong correlation. And you see that almost all of these, pulmonary, extrapulmonary, maybe extrapulmonary is more actually common than the pulmonary. So when you want to manage a patient with asthma, for the pulmonologist, extrapulmonary is also important. I think physicians are best suited for that. And these are all the various treatable traits. And then what happens to the risk of acute exacerbation? How common they are? It is quite complex. So every single patient, if you see, either one of them is dominant. These are pulmonary, extrapulmonary, and the so-called behavioral. The thickness gives you how common it is, and then you see, and these are thousands of patients, asthma, COPD as well as this. Each patient has their own particular combination. Here is a list. Because of lack of time, I won't go into details on all of them, but the funny thing is, you have a treatable trait, you have a very specific diagnostic criteria here, you have a very specific treatment given to that, and the evidence grade, a lot of them if you see are 1, some of them are 2, very rarely you will find 3. So every single treatable trait that you can put in for this patient, you will find there is a very specific diagnostic criteria for each, a specific treatment for each, with a fairly strong evidence based. So this is the way to go to practice every single patient. All of these, there are about more than 30 of these. You need to look at them in detail For example, you can get pulmonary hypertension, bronchiectasis, bacterial colonization, cough reflex hypersensitivity. Each of them have a fairly good treatment with the fairly strong evidence. Mucus hypersecretion, hypoxemia. So this is the way to go. These are all the extrapulmonary treatable traits that you can look at, including sarcopenia is there, obesity, deconditioning. These are all the extrapulmonary, looking at the cardiovascular disease, GRD, OSA, anxiety, depression, systemic inflammation. All these have very specific diagnostic criteria and fairly good treatment. These are all the behavioral risk factors, smoking, side effects also. They don't use the medicines, of course, exposure to indoor air pollution. So the concept now, when you want to talk of a personalized medicine for each individual patient in asthma, is to look at all these treatable traits, more than 30 of them, and then apply the best evidence. And so-called, now we talk about multidimensional assessment of intervention. That is the current gold standard of practice. Quickly go through studies in what we did in Mysore. Now this is what the current gold standard says. But is there something more than that? Yes, there are. And I will talk of disease progression, I will talk of treatment responsiveness, and we will look at our own kind of cluster analysis that we did. Nobody talked of disease progression. Even now, GINA doesn't talk of disease progression. Maybe the US NIPP just talks of that. But we define disease progression when over a period of time, you are following up the patient, say, for a few years. There's an increase in frequency of symptoms, increase in severity, increase in annual medication requirement, increase in time taken, more and more tissues are involved, and reduced response to treatment. So this we defined somewhere in 2009 when we published this. In the last 2 years, the US guidelines is now talking a little bit about disease progression. I think that is a good thing. And we found that 75% of the patients have progressive disease. None of these really talk about it or offer solutions. The one of the things that I have found that works well to halt the progression of the disease is allergen immunotherapy. The second important point I want to share is the treatment responsiveness. So what is this treatment responsiveness? This is something we did for the difficult asthma guideline for the American Academy. Is when you talk of responsiveness, it is how easily we can control a patient. We have a patient with lung function 20. Whatever you do, you will find that within a week they will come back to a lung function of 90. Whereas you have a patient with lung function of 65, whatever you do, you really can't bring him to lung function of 70. He still continues to be symptomatic even with the best drugs that you have. That's mild disease, poorly treatment responsive. Whereas the first patient, severe disease, highly treatment responsive. So that's the kind of things that we are looking at. So this is a study that we did with the funding from ICMR. We had about nearly 1,000 subjects, asthmatics as well as normal subjects. I won't go into the details except to say that we had people with poor treatment responsiveness. We did all the haplotype analysis, finally found that where these people had 400 ml improvement after 3 months of the guideline-based treatment, these people had only about 111. And how many met good treatment criteria? Nearly half the patients did not reach the good treatment criteria. We said, does the duration of asthma affect the responsiveness? No, it does not affect, but the severity of their disease actually affects. 70% of them could not reach normal lung function, 94% of severe asthmatics did not reach normal lung function. So this is the clusters, 100 patients, 6 months of follow-up. I won't again go into the details except to show that the 2 of the clusters were actually poorly treatment responsive. When we look at all the factors we looked at, but the main highlight here is the 2 of the 4 clusters were poorly treatment responsive. Now these were the 2 clusters. They were severe adolescent as well as severe much older, and they are a significant group of the population, both young as well as old. So why they could be poor treatment responsiveness? One, of course, is the actual treatment responsiveness. I'll go into that, airway remodeling, or even they could have small lungs. When we talk of poor treatment responsiveness, this is a study we did looking at, we use inhaled steroids for the management. Now, inhaled steroids, for it to work, to have an anti-inflammatory effect, has to bind to the glucocorticoid responsive elements in the DNA. Now this has beta receptor as well as alpha. If it binds to glucocorticoid receptor alpha, it's going to go to the DNA. If it binds to the glucocorticoid receptor beta, it's going to stay in the cytoplasm, and all the steroids you give has no effect. So we did this measurement several years ago when we looked at based on the corticosteroid use, because we found that after we start using steroids, patients become less and less responsive to treatment. Why this could be? So that is when we looked at this, and we found that as the patients use more and more inhaled corticosteroids, we find there is an increase in the glucocorticoid receptor beta in their serum, which we actually measured, and in their cells. We actually did a PBMC study with this. Airway remodeling, I just talked to you about ADAM 33, and this is a review I wrote. It has a very, very pleiotropic effect, and this remodeling can lead to poor responsiveness. Last but not the least, of course, is the small lungs. Almost 36% of the subjects who did not respond, who did not reach 80%, could be because Indians have small lungs. This is the COPD hypothesis from the Lang. This is the study which we have been doing now with the AIIMS in Delhi, St. John's in Bangalore, IIT Madras, as well as JSS Mysore. We have more than nearly 5,000 subjects screened. We have about 4,000 spirometries now. And if we look at 50% of these children, these are children 11 to 14 years of age, we are going to follow them up for the next 4 years, have below normal lung functions. And most of it is coming from Bombay. The best lung function seems to be in Bangalore. To my surprise, I thought Mysore would have the best lung functions. Unfortunately, it's not. Quickly, what is the future of the precision medicine? That depends on the endotyping. For the endotyping, we need something called as molecular phenotyping that has a particular pathway. And it's a very, very complex mechanisms. You have millions of these genes, RNA, proteins, metabolites. There are millions of those. I will go quickly. This is a study that we did for COPD, looking at tobacco smoking and biomass. And you can see the protein-protein interaction, and 15 of them are different. And this is just a very small part of the proteomics. And these are all the various neuromics platform. Single cell sequencing is the flavor of the day. And when we define endotypes, we need a particular pathway. I'm going to go through very quickly now. Now, even when we say T2 high asthma phenotypes, we have several subgroups among them. And when we say T2 low, again, we have several subgroups among them. When we talk of eosinophilic inflammation, it can be allergic, it can be non-allergic. Even the pollutants, microbes also can cause eosinophilic inflammation through the ILC2 pathway. To bring it more to confuse, asthma not only type 2 inflammation, you have type 1, gamma interferon Th1 also causes asthma. And then you have patients when you have a combination of both of these. To make the matters worse, we have something called as inflammasome in severe asthma. We have 3 different pathways that can go through, different kind of damages. You have the danger associated molecular patterns, you have the necrotic damage that can actually have one of these 3 pathways, and depending upon whether the Jun kinase or the nuclear factor alpha beta is activated, we get a severe eosinophilic asthma or we get a neutrophilic asthma. Microbe immune interactions are important. Obesity and asthma, very complex relationship. These are all the various factors you get in childhood asthma. So to conclude, asthma is a heterogeneous disease. There are several phenotypes as we have shown, and patients who are not responding to broad anti-inflammatory therapies, we need to look at their treatable traits, we need to look at specific biomarkers. Lot of comorbidities are important. Adherence issues, once they are looked at, then we need to carefully look at why they are not responding. And treatable traits is a good way to actually look at it. We need a large number of studies in India with the high-end approaches to actually come to precision medicine in asthma. And where are we now? We are at least 100 years away from it, actual molecular precision medicine. We did whole genome sequencing, 150 subjects, first time in the world, 30 members in the family, at least 12 to 15 should have asthma. We thought we will get all the answers. We remain more confused than ever at the end of it. Thank you very much.
Thank you, Dr. Mahesh. One for completing in time and for your redefining the treatment of bronchial asthma.
Thank you.
We can allow just one question if you have, please. Thank you.
Thank you.
Thank you so much for that informative session, sir. Next, we would like to invite Dr. Uma Maheshwari to talk about the role of inhaled corticosteroids in COPD.